Good afternoon, and thank you for attending the STN monthly webinar. This session is being recorded so that it can be offered as on-demand CE for our members. Your lines are muted, but if you have any questions during today's presentation, please type them into the question queue on the control panel, and we will answer them at the end of the presentation, time permitting. STN is an accredited provider of continuing nursing education. To claim CE for this session, you must attend the entire session and complete the online evaluation of the presentation. If you are attending this session live, you will receive an email 1 hour after the event with directions to complete the evaluation. Your CE certificates will be emailed approximately 7 to 14 days after today's event. If you are viewing this session as on-demand CE, you'll be able to download your certificate after completing the quiz and evaluation. Today's speaker is Daria Ruffolo. Daria spent nearly 20 years as a bedside nurse in a surgical trauma intensive care venue before taking on the role as an acute care nurse practitioner with the anesthesia critical care team at a busy urban medical center. Daria is a certified in both critical care and trauma. She is also credentialed as a certified specialist in adult care. In her role as ACNP, she does critical care evaluation, pre-operative assessment, and risk stratification for the operative patient population. Prior to this role, she served as the ACNP to the trauma surgical critical care team for 12 years. She has adjunct appointments in 2 collegiate nursing programs, published in multiple peer-reviewed journals and book chapters, and has spoken at over 200 national conferences. Daria has served as a nurse missionary in areas such as the outback of Australia, Papua New Guinea, Slovakia, Dominican Republic, South Africa, and Ecuador. Please welcome today's presenter, Daria Ruffolo.
Hello, and thank you for joining me. We're going to be talking about end of life and trauma, facilitating a good death after injury, which is often a challenge after taking care of very sick and critically injured patients. I have no conflicts of interest. There is my contact information. It'll be available. The slides will be available, I think, on a PDF later that they'll be posted. And so my contact information is there if you have any questions or concerns or anything you want to share with me, both phone number and email. Here are our session participant objectives. I'm not going to read them to you, but we're going to try to cover the conflicts we face as well as defining what a good death is after injury. What we do know is this, is that trauma is an irretrievable moment in time, and that's what we as nurses and care providers that care for trauma patients need to take into consideration. These patients are very different than others that have potentially had chronic illnesses, and now that they're in the hospital in an emergency setting, it's been something that's been leading up. But this happens at a moment in time. It's also a preventable disease. We didn't know until the 60s that trauma was actually a disease that could be studied, has risk factors, has means for prevention. So we as trauma nurses should be trying to put ourselves out of business with all the prevention techniques that we have available to us. But what we do know is that this is a disease that is here to stay. In the year 2000, there were about 5 million people that died in the United States as a result of injury. And we do know it's the leading cause of young people to die under the age of 44. It's the #1 reason why they would die. By 2020, there's going to be almost 9 million deaths caused by injury. And of those, about a third of them die from hemorrhagic shock. This is what we're used to seeing in the United States when we think about taking care of trauma patients. We have all this technology and all these current therapies available to us. And that's a wonderful thing. But what we do know is that these patients are getting sicker and sicker, and we're seeing more and more tragedy associated with injury. And we know that there is a trauma care showdown, that there are some things we can do for these patients and we should do, and we have good outcomes. But there's a point when we're taking care of these patients where we have to realize that maybe the success of this patient's care is not necessarily getting them back to homeostasis, but maybe providing them a good end of life. The United States today, again, we see trauma as a very rapid, a very high level, high critical care with a lot of therapies that we can offer our patients, and often utilization of many, many valuable resources. How many of you have seen something like this? This is actually a garbage can lid that we were transfusing a patient and we could no longer keep up with the blood bags, so we just tossed them on the floor. So there's a lot of resources, a lot of therapies we can offer patients, but we want to make sure that we're doing these in a timely fashion and with the right populations, because we want to know, where are we heading? When we take care of these patients, we think in terms of trauma ICU care as two major goals. Save a life with intensive invasive therapy, but one of our other goals, and we have to keep this at the forefront, is providing a peaceful and dignified death when death is inevitable. We often feel more like we're heading to the asylum. But what do we see on a daily basis? We as critical care and emergency room nurses attend to a large number of dying patients. About 20% of the critically ill and injured patients die while hospitalized. So those patients we're seeing come through the emergency room that are very injured, about 20% of all comers we're going to lose. Life and death decisions on these patients are made very quickly, and many of these patients are unconscious, and they have family members that are trying to make these decisions for them. Discussions with patients about limitations of the treatments have been relatively infrequent. Often these are patients that are disenfranchised from family. They're often have had little conversation about what they would like done at the end of their life. DNR decisions are made at the very last minute. We see this all the time in a practical application where we're looking at a physician and saying, what are we going to do? His blood pressure's tanking right now. And more common is for patients' families are made at the very last minute decision makers. When we think of end of life in trauma critical care, there was a study that was done in 2013, and it looked at huge hospitals in the United States. And they looked at 3 different providers and what did they think the goal of the end of a life was and what was really the purpose of their care. Surgeons felt the most important goal was defeating death. An intensivist, which would be more of a medical model, felt that they wanted to take into consideration the quality of the patient's life as well as the utilization of resources. When we looked at critical care surgeons, which is what most trauma surgeons are, they had a covenantal type ethic, that they believed that the surgeon defined their relationship to this patient as a promise to battle death on all fronts. The choice is simple, it's life or death, and the quality of life to this provider was not traditionally taken into consideration. It really was they wanted to see this patient survive. The goals of healthcare today in the trauma intensive care unit, in the trauma emergency room, we want to restore health, we want to relieve suffering, and these goals are not necessarily incompatible, but we want to offer treatment with a defined goal with a defined goal in a context of that particular patient. What we do know today, when we look at trauma critical care today, and a study that was done by the American College of Surgeons, and it said 10% of global mortality is from traumatic death. 20% that we said of the trauma admissions are going to die, and 35% of these people die after a very long, invasive, costly stay. Most of these are related to brain injury and spinal cord injury, but most deaths were very late, and they were with withdrawal of support. They were associated with pain and discomfort and obviously a lot of agony for patients' families. In 1998, this was years ago, 20 years ago, there was a study done that looked to understand prognosis and preference for outcomes and risk of treatment. And this was one of the foundational studies that looked at surgical patients, critically ill patients, critically injured patients to determine how much do we really do and how much do patients and families really want imposed upon them if they had a better understanding of the actual prognosis of the outcome. What we do know is this. In that same very year, the American College of Surgeons actually promoted that end-of-life care should be taught to the residents. And they put that in, their national guidelines. And then a very small survey study that was done in 2016 actually found that less than 10% of surgical residents that are in training taking care of trauma patients had any end-of-life care training. So we've identified that these critically injured patients can have a very rocky course that has an ultimate end-of-life decision-making, but we're not identifying when these decisions need to be made. So what about trauma patients and what about us? How do we differ from other patient populations? Well, many of these trauma patients, obviously, these happen without they're without notice, without any type of warning. So many are without any kind of advanced directives. Their families are often uncertain about prognosis. The functional capacity of the person is often severely limited. They're relying on surrogates. The surrogates are often themselves in significant crisis, wives whose husbands now are incapacitated, children that have been, harmed. And we know that they die late in their hospitalizations after an invasive costly care. But what about us? So we were attracted to and are directed our careers towards taking care of the traumatically injured patient are kind of a different breed in and of ourselves. We like a rapid resuscitation. We like an aggressive approach to care. We often see death as failure. We work in a culture of cure. We want people to get better. We often have personal beliefs about prognosis and functional outcome. You know, we say, hey, I've seen this level spinal cord. These guys never get better. I've seen this happen. These guys do very well. We have our own personal experiences where we've had care. So we bring to it what our own prejudices. We work at institutions, some which have incredible resources with rehab and support services. And that kind of directs how we see patients. We know they can get to the spinal cord injury program and the traumatic brain injury program. Or maybe we may work in places where there's very little resources. And that changes the way in which we approach the way in which we'll take care of our patients. What we do know is this, that the patient has to be in the center of this entire concert. And they have got to be the director of this concert. And so we want to, as nurses, facilitate as much as we can the patient that's been injured to have impact and a huge impact on what we're going to do with their care. Let's talk a little bit about the literature. There's a paucity of literature about end-of-life and trauma. It's, for years considered not an area which would be studied. There's some kind of smaller studies in the last 10 years that have been done. One was done by Ball and found in the Journal of Trauma in 2010, and they looked at 420 doctors. And these were the ones that were taking care of trauma critical care patients. 51% of the patients with end-of-life care was guided by the critical care team. Ethics and palliative care teams were available in these facilities 95% of the time, but they still failed to use them less than a third of the time. So the critical care doctors felt that they were able to manage end of life. But what they did find there was a significant disparity in the care in relationship to the staff and the way in which the care was approached, and the family members in the way the care was approached. So what we saw from this is that there are palliative ethical teams that are available, but traditionally the trauma surgical critical care people do not use them. Another study that was done by SICE, and it was in Journal of Trauma in 2013, and it looked at the withdrawal of care. It was a retrospective study, and they looked at withdrawal or limitation of care in 54% of all the deaths. But what they found is that when a person was severely injured, about 50% of the time they did the whole thing ended, they withdrew support. So they pushed, and then almost 95% of the time, within 24 hours, they made a decision, this isn't working, and withdrew care. And so that became a conflict for families, and obviously, that's again where palliative care and ethical teams can be involved. So it's not this push and stop, is what we've seen traditionally in some of the trauma management. The majority of the deaths that we see in trauma care is withholding, withdrawing support. The decision-making communication about these end-of-life decisions are often difficult. Again, fragmented families, families in tremendous stress. And then we also understand the hospital culture is very critical. So do we really get it? Do we understand what we're communicating to families, particularly on these families in significant crisis? So there was a study done in the Journal of Internal Medicine in 2013, and it actually looked at physicians and family interactions with family members that were morbidly either ill or sick, ill or injured. And so what they found in that one of the studies looked at an MD and family interactions. This was not a scheduled conference. This was a doctor who happened upon the family when he was rounding. And when they interviewed the family and the physicians after the interaction, they found that the doctor had spent 75% of the time talking. He or she missed important opportunities for patient families to discuss their values and the importance of their goals of treatment. But when they asked the physician how they felt the meeting went, majority of them, almost 100% of them, felt that was a good encounter. Then they also looked at a formal meeting where there had been a scheduled family meeting of the critically ill and injured patient with the MD, and it found that the doctor rarely explored the patient or the family's goals and values when looking at the care pattern. They avoided discussing anything that had any uncertainty and failed to explore reasons for these choices and failed to discuss quality of life after the treatment that they wanted to impose on them. For instance, putting them on a ventilator, amputation, taking them to another surgery, something like that. So an ideal ICU resuscitation goal would be both the living and the dying in an ICU system often involve focusing from the very beginning on comfort as well as cure. Palliative care must begin from the moment the patient and the family enter the healthcare system, providing the best possible patient and family-centered care, whether it's a great save or a good death. Those should be our goals. When we think about effective meetings with families, we know we want to meet early on and give them honest information. And we do know that most families and patients will make a good decision when given accurate information. Those families that are comfortable with the concept of end of life are more amenable to talking about a palliative approach. We know that these trauma critically injured patients should have regular routine family meetings. Some meetings are based on diagnosis, that we know that there's a severely injured, head injured patient or a spinal cord injured patient. Those usually end up having meetings early on. Some institutions do these based on time. What we do know is the literature shows that if a patient is in an intensive care unit for 3 or more days, the patient outcome and family satisfaction is improved if they've had a formal meeting within 3 days. This initial meeting should be scheduled, not just let me know when they show up, and more often or comprehensive as needed or if needed. This is not a new thing. We know that giving bad news from the family perspective has been around forever. And so there was a study done that looked at how do families receive this bad news. Particularly, this was in trauma patient populations, and they really looked at patients' families being told that their family member had died. And then they got a response rate for this study of about 55 family members. Their injury pattern was, how it just kind of mirrors nationally, mostly bluntly injured patients. But they wanted to ask, when did you find out that your family member died? Was it before death, when they were just dying before you, after the death, or never? And so about 44% were told before the death, but the death was imminent. And 26% literally were told while the patient was dying before their very eyes. Who gave them the news? When the family members were interviewed, they really had little idea about what doctor was giving them. They quoted, hand quote, doctor. They didn't know if it was a resident. They didn't know if it was the attending. They didn't know if it was their family members attending. But about almost 60% of the time, the person that gave them the information, they didn't know. And then they asked where were they told, and it was various places, conference rooms, waiting rooms, hallways. The attitude, what they valued, what the family members valued when they were told that their family member had died, was the attitude of the person who provided it. Were they clear about it? They should provide them privacy. They were knowledgeable. They knew who their family member was. It wasn't someone sent in there and said, I'm here to tell you and I don't know anything else about your family member. They were sympathetic. They allowed time for questions, information about if an autopsy was necessary, and clergy was available. This is interesting. When they asked the family members who were being told that their family member had died, they were asked them about physical contact, and they said 30% of the time they did not want to be touched. 17% said some touch was desired, and 7% said only a handshake, and about 46% no comment. But 30% of people responding there did not want to be touched. Nearly every respondent had these 4 elements. They wanted the person who gave them information to be empathetic. They wanted them to be clear. They wanted to have a good attitude or a compassionate attitude, and they wanted them to be able to answer questions. 87% had positive comments, and interesting, most of the positive information comes back in reference to the nurse. About 12% of the comments that are negative come back related to the physician. Comments they said is be kind, direct, and to the point. This is heard over and over and over again. I've been in family meetings where it's not even clear if the person's alive or dead, and the family have to finally say, are you telling me my mother's dead? So you want to be, look them directly in the eyes and briefly share the pain. Speak to the people compassionately. He says he gave us a chance to talk about our dad. It was a positive memory. The ER doctor realized my mother was alone and arranged for us to get a neighbor. How you say things to patients' families matters. There was a study done by the surgeons and the tone of their voice. And what they found when they scaled the voice was their anxiety, warmth, interest, hostility, that the more aggressive, more dominating the responses were, the more likely that surgeon would be sued. And this is nothing new. There's been studies that have been done, for decades looking at how we respond to patients. It really has an impact on how they will have a long-term effect on this end of life. Terminal care of patients and families is not new. By 2004, the Robert Wood Johnson Foundation came out and said there's a better way to die in the United States. In 2009, the American Trauma Society actually came up with something called TLOS, which is Trauma End-of-Life Optimum Support. And it was actually a best practice model, educational processes, there were support tools in place, and it's not ever really been able to take loft in the Trauma Society. We know that there are many ways in which we're communicating to the general public about death. There's a book recently published called Modern Death, looking at a lot of critical care and trauma patients. Atul Gawande on Being Mortal, and When Breath Becomes Air is a recent publication. So these are not new concepts. Terminal care of the patient and the family and trauma is unique, that we do not know our patients before illness or injury. There's a suddenness and an unexpected nature of this disease, and there's a heavy weight on the patient's life and responsibility. Often this is the primary provider for this family, and that they are left, aloft because they no longer have this person who's leading the family. When you talk about chronic illnesses, when you lead to death, you have this kind of seesaw type of admissions and discharges, admissions and discharges. When you look at trauma death, you see that this is, statistically shows a pretty steady decline, and that these patients usually come in and have a pretty quick trajectory to their death. The problem is that we need to know the goals of these care. When we're talking about injury with these patients, we need to assess and understand. That's why meetings are so important when you think about end-of-life care on these patients we know nothing about. And you may meet with families with assess the understanding of, tell me the understanding of your brother's condition. What have you been told so far? What would you think and hope would happen from here on? What is important for your brother to be able to do to have a meaningful life? Because again, this person is often not able to speak for themselves. Restate and clarify in this meeting the patient and family goals. From what I'm hearing is that he's always been strong. He's always been able to overcome challenges. And you think that he can pull through this. Our goals of this care is not to dash every hope, but to make sure that we are able in these meetings to communicate what they understand, reiterate that back to the family, and to clearly let them know where we see this patient, where they stand. But then you have the sister from Arkansas who arrives, and she sees her 85-year-old brother who's been in a motor vehicle crash with a pelvic fracture and facial fractures, and he's coded in CT. They did CPR on him for 20 minutes. He's in the ICU. He's on 2 pressors. And the sister says, whatever you do, I want everything done. Do not back down. What is everything done? We've all faced this. When we know patients are moribund, we know that they have insurvivable injury, but families say, this is my family member, you work for me, I want everything done. We need to determine what they mean by that. Most families just want reassurance that their loved one did not have a survivable injury and that they got everything done that was appropriate. If the goals are medically reasonable, we may reassess in a couple of days and rediscuss the progress or lack thereof. If these goals, if they're telling you, I don't care what you say, we had a patient who was brain dead, and a family member said, you are not turning that ventilator off. We cannot accept medically unreasonable directives. So try to negotiate. I wish this was the case, but unfortunately, most patients who are injured as he is don't do well. They will not get better. So it's not going to happen. If this is not going to happen, what can we do to help him? Consider a time-limited trial. We do this often. We can continue to support him in the hopes that in the next couple of days, with some fluid resuscitation, his kidney function may return. We know that his pneumonia is, being treated. We may give him a couple more days of antibiotics and see if he's going to do better. It will be unlikely. Something that we can tell them will negotiate a short limited therapy and reevaluate. Can we get this information across to them? There's actually a tool called the best case, worst case framework. This was developed actually by a trauma surgeon. She uses it in her general surgery as well as her trauma surgery program. And what it is that you provide a scale. And this at the top, it says surgery, and at the bottom, which is the best case, and the bottom, it's the worst case scenario. Also on the other side, with palliative care, the best case, the worst case scenario. And you can actually write on this scale what most likely is going to happen. The best case, your patient's going to have their surgery, they're going to, do well, they're going to go home. Most likely, they're not going to do well from this surgery, and they're going to end up in a nursing home or on a ventilator. Worst case, they're going to die from this. So you're able to kind of give a tangible scale to the family members. And the surgeons have found that they find that this is helpful. This is an example of an actual case. The family member said that it's not something they want, that she would want, when they were able to tangibly show that most likely your family member will never walk again, never speak again. And so both families and the surgeons were able to be able to use this as a tool when they're talking about end of life. Rather than standing in a hallway and just kind of giving them the options, you were able to give them something tangible. What was going to, best case, worst case, most likely. And family members even reported they used this tool and brought it back to other family members to show this is where we stand. And it helped them in decision making. But we've got to be compassionate. But we do know this, is the American Medical Association says physicians are not obligated to provide care to these trauma patients that is physiologically futile, even if the patient or family insists. We're not obligated. How about letting family members in during resuscitations? We know this has been sanctioned now for a number of years. Most all trauma associations and medical associations, as well as nursing associations across the country, say that family presence, particularly during pediatric resuscitations, has been effective. There was a study done that looked at nurses and doctors and found that the nurses at a 2-to-1 ratio would rather be with their family members than physicians during resuscitation. But we know that when we query family members that have been there, 75% of all family members, desired wanting a presence to be there, and only obviously not 100% are able to be in with resuscitations. 94% would make the same decision again, even though they had seen what would not be a pleasant a case unfold before them. 100% believe that everything possible was done because they were there. They were able to see and did not feel that any corner was cut, anything was done abruptly, or that services were stopped. They look at it from the patient's perspective. They were comforted. They were reminding of the patient as a person. And so what we did find is that families that were present during a resuscitation had lower bereavement scores and actually did better when they looked at their overall recovery from a death. We, of course, worry about the ability to be able to teach during a resuscitation. We worry about the validity of a family. Are they going to, faint? Are they going to become hostile? We feel that staff can't deal with both the patient as well as the family, and that we may change the way in which we approach our care delivery. How about CPR with these patients? We're talking about these, critically injured patients that are in the ER or the ICU. What are we doing about these DNR orders? So CPR was developed in the 60s, and it really was intended just for a very select population, those that were drowned, those who had drug intoxications, an acute heart attack, or an asphyxiation. What we do know is that over 80% of patients that have CPR on the television, it was never intended as a routine therapy to be entertained at the point of death on patients. It's unclear how it became a standard of care, and it's very unique in that it's the only medical intervention that we require an order not to do it. So if you think about it, you don't have, when you admit a patient, there's not order because often medical teams will say things. My own father, they told me, we would be able to diurese him, but you did put him on the floor. So we make decisions based on their end-of-life care, but a DNR does not preclude that they do not get other treatment. We want to think in terms of when we're taking care of these family members, we want to respond to the effects, what's happened with this injury with affection. So when we're having these interactions with them, it's often a skill we learn over time in that you want to be able to respond appropriately. I can see this is hard for you to hear, and reflecting on the emotion in the room. When there's silence, can you tell me what your thoughts are? Have you thought about this before? And allow silence where you think it sets the tempo. Patients and families see this as out of control situation and try to give back as much as you can. What gets taken off the table and they say, wow, I just made him a DNR. That's a huge thing for them. You want to put something back on, and that we're going to be able to control symptoms. We're here to support you. We can offer potentially hospice care. You want the population falls well within the palliative care group. Often the palliative care team is the elephant in the room. We know that palliative care nationwide has become a very, very prominent member of the trauma critical care team. And we want to make sure that we do not leave them out of our care armamentarium. No longer is the pattern like we see on the top slide where you do everything, and then a line in the sand is drawn and you make them a DNR and hospice is brought in or you draw their care. When in reality, we can have a life-prolonging care and we can mirror that with a palliative care approach as well, and possibly hospice at the end. We know that patients that have been traumatically injured can have palliative care approaches as well as continuing life-prolonging care. And what this slide shows is that when we think about patients that have standard care versus palliative care, that they will no longer have dramatically aggressive end-of-life resuscitations. That we know that when we've entertained palliative care, we're more likely not to have last-minute DNRs, last-minute doing chest compressions on patients we didn't think we should, intubations on patients that probably were not appropriate. We know that their resuscitation preferences are documented. 53% of the time, a DNR is appropriately on the books. And we also know that patients that are in palliative care certainly live a little longer when we look at patients that enter into hospice care, and they actually have better end-of-life management. So palliative care and the critical care venue has been around now. We know that IHI and a lot of different other associations are advocating it. The palliative care approach to ICU trauma care has been actually founded in the Mount Sinai School of Medicine, and it's improving ICU care. It was identified by the National Institute of Health and the Department of Aging. And what it is, it's an online critical care approach to getting palliative care involved in the critically ill and injured. And there's tools on there for you to select the criteria, consulting pathways, care trends. There's tools to educate family members, staff members. It's open and closed units are often an issue. Open units are those that actually have other physicians that may be managing those patients, where closed units are those that are more likely to be able to put a project in place without having to deal with multiple different care patterns. What they found is that when patients were involved in this IPAL, or improving palliative care in the ICU, they actually lived longer, and their mortality rates at greater than 7 days increased. So what they found is, again, it's not those aggressive last-minute approaches to intubation, CPR, or radical withdrawal, but a slow approach to end-of-life management. So there's some strategic partners in looking at palliative care. So let's talk about some practical application to what you're going to see in your critical care venue, taking care of these trauma patients with a palliative approach. Pain is huge. So from a trauma standpoint, from time immemorial, we've used opioids in management of their injuries. What we do know is what palliative palliative brings to the bedside for our patients with spinal cord injuries, for our patients with brain injury, for increased intracranial pressure, for crush injuries, for visceral distension from, huge abdominal compartments and things like that. Steroids are introduced as a way in which we're able to manage those. What we use is anticonvulsants to help with nerve pain. The NEMDA approach for antagonistic pain management, using things like ketamine and methadone, which are not traditionally used, antidepressants, and even topicals are used. We know that dyspnea is a common problem that we see with these patients, particularly, some trauma patients where we may see where they have chest injuries, rib fractures, particularly if they do not want intubation and we're dealing with, work of breathing. Assess and treat the underlying cause, whenever possible. Opioids, again, are the most studied and effective way to deal with dyspnea. We're going to talk a little bit about the principle of double effect. What we don't often use for the treatment of dyspnea is anxiolytics, which palliative care brings to the table. Let's talk about the use of oxygen. There is maybe a benefit, but what they find at the end of life, greater than 75% of patients are not hypoxic that are being treated with end of life care. They may have some visible appearance that they're doing some strange breathing patterns or maybe breathing deeply, but actually clinically they're rarely hypoxic. And when they studied them, the relief of what we thought was work of breathing was the same as with oxygen as blowing a fan over their face. So again, what they entertain here is the use of opioids, benzos, even cool packs or dark rooms. Now, when we think about the nurse caring for the trauma patient with palliative approach to end-of-life care, there is a principle of double effect. And what this is the treatment is at least neutral. We have a patient that they're in pain, they're, significant work of breathing, they have, very morbid injuries, they're at end of life, and we're administering anxiolytics as well as opioids to this patient. This may have a negative consequence, but the treatment goal was neutral. You did not want to hurt them. The intended positive outcome, but there was actually ended up being a negative outcome to it. And that's what this double effect is. Let's think in terms about some nursing interventions, and they look at the family's perspective at family presence during the end of life. And what they found is that they found the nursing staff kept the family informed. They provided assuring attentiveness. They were compassionate. They facilitated the final acts by supporting the family. And actually, it's been noted in scientific studies that nurses that were very involved in the end-of-life management of these patients actually showed that the family members had less post-traumatic stress disorder. All nurses can provide care stated by the American Nursing Association Code of Ethics to alleviate suffering and to provide interventions to relieve pain and other symptoms in a dying patient, even when those symptoms entail the risk of a hastened death. So you have a hypotensive patient, a patient that's, has significant injuries, they're breathing very, very heavily, and now you're giving them narcotics routinely, and your concern is that potentially you may drop their blood pressure or make them stop breathing. But when you're treating the symptom, even if it may hasten their death, we as nurses are sanctioned to do that. It's all about the goals for moving from, the administration of all kinds of high-tech therapies and medications to comfort measures. Let's skip that. So palliative care at the end of life has a bundle of care, and this is why palliative care physicians that are involved in this are much more likely to make sure all services and all systems are involved. Because we as trauma care providers often think in terms of hypoxia, hypotension, blood loss type directed resuscitations. When we're thinking in terms of palliative care, it's not only pain relief and anxiety relief. Right away, we want the code status known. We want the advanced directives in place, social services, pastoral care involved. They're able to treat GI symptoms, the dyspnea, and these are reviewed daily. What about fetal care? I told you that we had a patient that was literally brain dead that the family member insisted that we continue to care for. So how is fetal care defined? The disease must be either terminal or irreversible and death be imminent. And we see this in trauma all the time. Profound traumatic brain injury, imminent death on these patients that are, we've resuscitated and we cannot stabilize them. It merely preserves a permanently unconscious or cannot end dependence on intensive care management, someone who's permanently on a ventilator that's not going to come off. A clear legal definition does not exist, but we do know there's some equations when we think about trauma management. An example of physiologic futility. Treatment physiologically is unable to achieve the desired result. So we have a patient with a cervical spine injury and cervical spine fracture with a spinal cord injury. So they're able to stabilize the spine, but the cord has been permanently injured. That is a physiologic futility. We can quantitatively look at futility, and the likelihood of a desired result is very low, but not zero. Here's another example. So we have a patient with a severe traumatic brain injury. What is their likelihood to return to functional state, normal functional state? We know those are 1 to 3%. So these are examples that we can share with family members when we think in terms of futility and understanding, being able to give them some physiologic or quantitative definitions. We don't like to care for patients that we see as futile. We're people. We want to minimize suffering. We're reluctant to provide care that we know is not going to be good for the patient or the family, and we know it's not a good use of our resources. We seeing families aren't following our recommendations. We're thinking that it's time to start cutting back on some of the therapies, and we have feelings of distaste at inflicting physical abuse on dead or dying patients. Futile care is very, very problematic. I'm going to actually skip that. How about withdrawal of care? This becomes a little problematic for some care providers. They get concerned about once something's in place, you can't go back. Well, that's not true. Discontinuing a therapy that was just proportionate burden without achieving a goal. So we put something in, we thought it was going to achieve the goal, and now it has become a burden, be it an ECMO, a ventilator, an LVAD, something that we thought would get them beyond the stage they are now with an improvement in their outcome, has now not obtained that and is now a burden. They're infected from their line. They're, recurrent pneumonias, skin breakdown, something like that. Withdrawing treatment distinguishable from purposely hastening death. These are not intentional. So not initiating a treatment or withholding it has a disproportionate burden without achieving reasonable clinical goals is appropriate. So not putting something in place because it's not going to change anything. An example is we have a patient that comes into the emergency room. This is an actual case of an elderly person fell down his basement stairs. He's a C2 fracture complete. He's 93 years old. The idea of putting him on a ventilator is not going to change this outcome. So we withhold putting him on a ventilator, understanding that we're never going to achieve any reasonable goal with him. Withholding or withdrawing is not any different. The distinction between failing to initiate or stopping a treatment is artificial. You have to have the justification of why you're doing or not doing a treatment. Withdrawing and holding in 1988, 50% of all ICU patients died with the withdrawal withholding of their treatment. In 2010, 90%. So we're actually understanding and identifying, particularly in the trauma ICU, patients that no longer are benefiting from our therapies and making aggressive decisions about palliative approach to care. That includes a do not attempt to resuscitate, and there's a European term that's used, allowing natural death to take place. There's a study that was done in 2016 in New England Journal of Medicine, and it looked at 15 ICUs, about almost 900 patients, and they were looking at withdrawing of mechanical ventilation. So they made a decision on these, like, almost 900 patients. These patients we're going to see about getting them off the ventilator. They were able to successfully wean about 500. 140 of them died before they even got into the process, and they withdraw support on almost 170 patients. So they had some criteria that they used, and this became kind of a little bit of a controversial study. But and then they had non-predictors, but the emphasis was that life-saving therapy was not able to reverse the underlying disease. And that's what they identified in all those patients that they withdrew the support. Removing a life-sustaining therapy is allowing the disease to take its natural course. And this is an aggressive palliative approach to care. And this is what we see often in the management of the trauma critical care patient. And again, why those early meetings are important to understand, because often patients are putting on ventilators and have these invasive therapies entertained early on in their resuscitation. And we want to set into place what is the long-term goal. So when we get ready to make decisions or discussions about potentially removal of life-sustaining therapies, patients' families need to have been hearing this over and over again. So let's talk a little bit about a terminal wean. How do you do that? So, you have a patient already on a ventilator, and you're going to decide you've made the decision that this ventilated patient is no longer going to progress. The family and everybody is all, involved in this decision making, and you actually are going to wean them from the ventilator and just let the disease take its course. So you want to have some prep work, you should have policy and ethics in place. You don't want to be hitting the panic button at the last minute. So it is okay when you look at presidential commitment on the study of ethics treatment. Withdrawing ventilators are okay. There should be protocols in place. You want to make sure you have physician orders in place. There's two ways in which you can do it, a gradual or immediate. This is a shift in the priority of your care. You want to involve families, again, early on. You want to have careful monitoring for signs of any discomfort or anxiety, of work of breathing. Most of these patients are already under some type of altered consciousness, but you want to make sure that they're going to still have some kind of medication infusing. These are often very medically complex patients with lots of things going on. So we're changing our approach. Again, this is often a new culture for us as trauma nurses caring for patients. Be certain everyone's on board. I would have an attending present. Minimize the environment, turn down lighting, restraints off, side rails down, get as much equipment out of there, get good IV access. You only monitors that are going to help you understand if they're comfortable. Heart rate, monitors should be silenced. You may have a BIS monitor in place, which could look at bispectral analysis of brain activity in case there seems to be some agitation. They shouldn't be on neuromuscular blockade, so you can determine if they get agitated. Suction them before you're going to start any treatment, any weaning of the patient, and make sure they're in an upright position. Use sedation and analgesia, usually with continuous infusion. There's been multiple studies shown that you are not preempting their death by the amount of there's not a correlation between your sedation and analgesia and the duration of their survival. You treat their symptoms. So there's a gradual withdrawal where you start to have short increments of reduction of rate and PEEP. And then once you get them down to zero, the ventilator is taken off, and then you just have them by blow-by. It's highly suggested that these patients are not extubated because there can be stridor, or it can be the immediate ventilator withdrawal where you just completely take them off all ventilator support, maybe put them on a little blow-by oxygen, and again, medicating them as needed. If you are going to extubate, you do concern yourself with a little bit of a death rattle. So there's actually some suction devices that are out there to help you suction them very clearly before you extubate. Again, put the head of the bed up as high as possible. Here's a successful strategy that was done looking at an end of life in trauma burn care. There was actually an institutional policy in place in 2001 for this particular institution, large level 1 trauma center. And they found that no one was actually using it. So what happened is a fellow joined the team. He pulled this old policy, added some specific order set, put a standardized checklist of criteria and indications. He became the physician lead, and then the nurses became involved in house-wide education. What they found in 2012 that they identified early on appropriate care patients, that were appropriate to meet their needs of palliative care. They discontinued the orders. They were able to get a DNAR order right away. They removed invasive devices. They removed equipment from the room. They liberalized visitation orders. They were able to, with training of new staff and new nurses, advocate for a very effective palliative approach to end-of-life management in the trauma burn population. I'm going to skip this. Now I want to finish this. I've got a few more minutes left here, and this just gives us an idea of who we are and what we really believe when we think about end of life. So this was a study that was done looking at preferences for end of life care after injury. And it looks at the public and the professional, which would be trauma physicians and nurses. The first thing here is if a patient is dead at the scene of an accident, to which facility would you want to be transported? If you notice there, 37% of the professionals said they wanted to go to the hospital. And if you said you wanted to go to the hospital, why did you want to go? 14% almost said the reason they wanted to go to a hospital because even though they were dead, they hoped that something else could be done. So we often, are really kind of accusatory to family members, but we often think the same way. Another part of it said, if you were in an accident or likely to die despite any of your treatment, what would you like the medical team to do? Focus on making you comfortable 72% of the time. That's the professionals. Do everything they can to keep you alive, even though you know it's likelihood you're going to die. 23% of the time, the trauma healthcare provider said you wanted everything done for them. If the patient was a loved one, would you prefer the medical team to do everything, even if you thought they were going to die? 25% of the time they said, I want everything done, even though it looks like they're going to die. If the doctor believed there's no hope of recovery, would you prefer life-sustaining treatment, be stopped and focus on comfort? They said 92% of the time, yes. Should your medical care and resources take away from patients who are more likely to survive, would you still want to have your therapies? 24% of the time they said, even though there's no hope for recovery and my therapy is going to take away from someone who could recover, 24% of the time the trauma doctors and nurses said, I still want my care taken. And then here's that. Do patients have the right to demand care that the doctor thinks will not help? The professionals said 44% of the time, yes. If you were in a permanent vegetative state, would you prefer to be alive, kept alive, or to die? 3% of them said, keep me alive. And when they asked why, 20% of the healthcare doctors and nurses said they believed a miracle might come and they could be saved. So care versus cure is our debate here. Palliative care and curative care are not mutually exclusive after trauma. They're not dichotomous. We can entertain end-of-life care. Strategies for a successful end-of-life protocol is you want a medical group in place that's going to be key players. Review your past approach and find where you can integrate new models of care. How to handle when other physicians are working in your unit and they don't really go along with your guidelines and approach. Meet regularly with care teams and team members. Educate and educate, because death is a process, not an event, and dying in dignity is as important as preserving life, and palliative treatment is crucial in part of our palliative approach to trauma management at end of life. Withdrawal and withholding are equivalent, and early and frequent communication with families is vital. We all have an opportunity to shape our practice, and that's it. Thank you.
Thank you, Daria. That was a great presentation. I had a few people reach out in the questions say that they really appreciated it and they'll be showing this. If you have any questions for Daria, please send them to info@traumanurses.org and I'll send them to her and she can respond. As a reminder, this session was recorded and it will be posted to the STN website by the end of next week. In 1 hour from now, you'll receive an email with instructions on how to obtain CE credit. There's also a survey link. Please know that the survey must be completed in order to obtain CE. Thank you and have a great rest of your day.